Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past and present. I'd also like to acknowledge and thank Telematics for providing us with the funding to deliver this webinar. The focus of this webinar will be on the latest updates in ovarian cancer. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour you can ask questions to the presenters by typing into the chat box at the bottom left-hand corner of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 664 334. This webinar is being recorded and will be posted on the Ovarian Cancer Australia website at the conclusion of the webinar. If you're having trouble with the sound, you can dial the 1800 number listed in the chat box. We could just go to the next slide. So I'm extremely privileged to introduce our presenters to you. Our first presenter is Dr. Yolanda Antill. Dr. Antill is a medical oncologist and cancer genetics specialist at Frankston Hospital, the Royal Melbourne Hospital and Breeding Health in Melbourne. Her interests are in the management of breast and gynecological cancers. Dr. Antill is involved in the development and conduct of clinical trials and has published over 30 papers in international journals. She has more than 15 years' experience in both medical oncology and in the diagnosis and management of hereditary cancer syndromes. Dr. Antill will talk about some of the current research in ovarian cancer, including the SOLO-2 trial, looking at the use of Olaparib in early ovarian cancer. Our second presenter is Dr. Tarek Menyawi. Dr. Menyawi is a medical oncologist who subspecialises in gynecological cancers and who holds consultant appointments at St Charles Gardner Hospital, the King Edward Memorial Hospital, and St John of God Physiatric Hospital in WA. Dr. Menyawi will talk about clinical trials and new therapies in ovarian cancer, including PARP inhibitors, immunotherapy, and the timing of different treatments. And our final speaker is Ms. Vicky Sidotti. Vicky was diagnosed with stage 4 ovarian cancer 5 years ago at the age of 54. She has three children and 9 grandchildren. She's undergone surgery and chemotherapy to treat her ovarian cancer, and she was part of a clinical trial for Olaparib. Vicky, who will be joined by her lovely daughter Angela, will share her experience of being on a clinical trial and why the trial was so important to her. So I'd now like to hand over to Dr. Yolanda Antill.
Hello everybody, and welcome to the webinar. I am a medical oncologist and a cancer genetics specialist, and it's a privilege to talk to you tonight about some of the latest developments in ovarian cancer, and in particular how Australia is really helping lead the way in understanding the background and translating that background scientific research into how we can change the face of ovarian cancer forever. So the vast majority of the talk is going to be based on an understanding of what we know as epithelial ovarian cancer. There are 3 different types of main ovarian cancer, and epithelial is by far and away the most common. But even within epithelial ovarian cancer, there are a number of different types of ovarian cancer, and we're going to focus in on some of those more rarer or subtle subtypes. Dr. Tarek is going to take you through the more common treatments for the more common high-grade epithelial ovarian cancers. So I thought we would take this opportunity to talk about some of the more unusual or uncommon types of ovarian cancer. So most epithelial ovarian cancer has traditionally been treated with chemotherapy, and the backbone of chemotherapy in ovarian cancer is platinum-based. But there is much discussion now over the role of something called intraperitoneal chemotherapy versus intravenous chemotherapy. Intraperitoneal chemotherapy is given at the time of your surgery, where the chemotherapy is actually bathed around the abdominal cavity at the time of your surgery. This is given at the time of your surgery and then is followed by intravenous chemotherapy. In some of the research that has been done, the intravenous chemotherapy is given for a number of cycles prior to the surgery, and then the surgery takes place with what's called the debulking or removing of the ovaries, the fallopian tubes, and the uterus or womb, as well as any other sites of ovarian cancer that the surgeon can see. This would be followed by bathing the remainder of the abdominal and pelvic cavity in chemotherapy that has either been warmed or at normal room temperature. Some of the latest developments in the treatment of epithelial ovarian cancer is in immune therapies, and Dr. Tarek again is going to take you through lots of those changes. I want to focus on a very rare type of ovarian cancer called the mucinous ovarian cancer. So this is probably the least common type of ovarian cancer and really varies from very low grade and very low growing cancers to very fast, very rapid and very aggressive type of cancer. Until very recently, it was thought that the low grade was not actually related to high grade mucinous ovarian cancer, or even that high grade mucinous ovarian cancer may have actually arisen in other sites in the body, such as the stomach or even the bowel. So Australian scientists led by Kylie Gorringe and our team have forged collaborations with many other sites around the world, including North America and the United Kingdom, to collect samples from 300 women who had mucinous ovarian cancer. These ranged from pre-invasive through to the very high-grade ovarian cancer, and some very exciting discoveries have been made as a result of these very extensive body of work. One is that there really is a continuum between low grade through to high grade, and even prior to the low grade invasive, what we call borderline ovarian cancer. We have been able to identify a number of what's called targets, so a number of changes that occur in the genetic makeup of the tumour that could potentially be targeted, and we're going to take forward these works in the near future, hopefully within some clinical trials. Very importantly, mucinous ovarian cancer is very different from the majority of ovarian cancers in that platinum-based chemotherapy is relatively ineffective in the vast majority of these cases. And as such, the PARP inhibitors that are used in the setting of high-grade serous ovarian cancer is ineffective here. In addition, it appears that immunotherapy is unlikely to have a significant role in the treatment of mucinous ovarian cancer. However, with all the trials that have been conducted and the number of changes that have been found, it is thought that about 80% of women with mucinous ovarian cancer would have at least 2 possible targeted options to manage or fix their mucinous ovarian cancer. That's very exciting. It's very early stage, but it's a big step forward than where we were even 5 years ago. So the second group I wanted to talk about tonight is the low-grade serous. So that again differentiates from the majority of women who have high-grade serous ovarian cancer. This is the group of low-grade serous tumours. The Australia and New Zealand Gynecology Oncology Group, known as ANZGOG, have helped investigators move forward on a study of women with low-grade serous and endometrioid types of ovarian cancer, as well as those who had recurrent borderline tumours. All of these tumours had expression of estrogen receptors on the surface of their cancer cells. These tumours are not usually responsive to chemotherapy, but they can quite often be a fairly slow growing, but over a number of years rather than over a number of months. Again, these cancers are not usually responsive to the platinum-based chemotherapies that are usually used in ovarian cancer, and they are not associated with BRCA mutations. So this study looked at the use of an oral anti-estrogen therapy called anastrozole and found a clinical benefit of around 64% of patients at 3 months, and in just under that at 6 months. This is a treatment that's really well tolerated by most patients, with the side effects very classically those of those anti-estrogen or menopausal type side effects. A third group that I wanted to talk about is clear cell ovarian cancer. So this is an ovarian cancer that's often associated with endometriosis, is more common in patients of Asian ethnicity, and in fact is often presented with a large early ovarian cancer that doesn't spread to other areas of the abdominal cavity. It really only represents a very small number of patients who have recurrent ovarian cancer. Often, if it is recurrent, it is less sensitive again to platinum-based chemotherapy. In the past, clear cell has always been put in together with other ovarian cancer trials, but very excitingly, Australia is going to be involved in a clear cell ovarian cancer trial looking at more targeted therapy at the genetic changes that occur in this type of ovarian cancer. Finally, I wanted to also look at endometriosis as another subpart of clear cell. So I have been involved in a study in Victoria looking at the genetic contribution. So this is whether we can discover genes that might be shared by women with endometriosis, where we know that there is around a 51% rate of other family members having endometriosis if one member of the family is identified as having endometriosis. We know that endometriosis affects up to 20% of women who are of reproductive age, and it's where these areas of what is normally contained within the lining of the uterus or womb seems to efflux out, probably through the fallopian tubes, into the abdominal cavity. Can often cause problems with fertility, is often associated with very significant pelvic pain, particularly around period time, but is also associated with an increased risk of ovarian cancer. So we used around 600 patients from the Variants in Practice or VIP study that has been carried out in Victoria for women who have undergone genetic testing with a history of ovarian cancer who were not identified as having a BRCA genetic change. We found 25 patients who had ovarian cancer arising from an area of endometriosis, and we have searched extensively through their genetic material to come up with 14 possible genes that might relate to an increased risk of hereditary ovarian cancer related to a background of endometriosis. So further work is planned in this with a collaboration of a large group of endometriosis researchers from Melbourne and Queensland, as well as, again, international collaborators. I wanted to take a sideways step now and talk about genetic testing. So a term called treatment-focused genetic testing is where genetic testing is carried out for patients where a genetic change is likely to immediately change the treatment processes by either changing the surgical plan, whether radiotherapy is used or not used, or choices in systemic therapies like chemotherapies or targeted therapies. For women who have been found to have ovarian cancer in the setting of a BRCA change, PARP inhibitors have really changed their treatment options, particularly in the advanced or recurrent ovarian cancer setting. Of course, finding a genetic change in an individual who has ovarian cancer is not just about treatment-focused testing, but also about opening up predictive testing for their family members to see if other family members also have an increased risk for ovarian and the other cancers that might be associated with that genetic change. Genetic testing is now carried out in a panel of genes that can lead to an increased risk for ovarian cancer. But over the last few years, we have realized that it's not possible for all women to make their way from their home hospitals or treating team to a specialized genetic center to undergo genetic testing. But because we know that around 15 to 20% of patients who have ovarian cancer have an underlying genetic change in a hereditary cancer gene, and that this would influence the treatments that their home team would consider, but also importantly, it's about uncovering genetic susceptibility in their family members. So we've been involved in teaching healthcare providers of patients who are treated with ovarian cancer about how to provide genetic testing in their home centres. This is called mainstream testing. This is where the genetic test is provided in your home hospital, not in your actual home, but in your hospital by your healthcare team, and you're referred on to a family cancer centre only if a genetic change is found or if there's additional significant family history of cancers that it might also need to be explored by the family cancer centre. This means that there are fewer appointments for women and their family to have to attend, and particularly at a time where they might be undergoing significant chemotherapy or just have had surgery. It also means that results are getting back to our patients faster and to their treating doctors. The other big change that has happened in the last few years is that there is now Medicare rebate for people who have ovarian cancer under the age of 70 or at any age if there is some additional family history of cancers that would suggest a raised possibility. The alternate to a Medicare rebate is where the Family Cancer Centre would fund the testing for women with ovarian cancer. There is also some new upcoming possibilities of actually doing genetic testing in tissue that may be stored. Why might this be useful? This might be useful for families who sadly have lost one of their family members to ovarian cancer in the recent past, where the actual gene testing might be able to be carried out on the tissue that still might be stored in the pathology laboratory. So while we know that PARP inhibitors, a targeted therapy for women who have BRCA changes, has been used in the setting of advanced or recurrent ovarian cancer, the recent SOLO-2 trial has been presented at the end of last year. This is where Lynparza or Olaparib is given to women following their primary chemotherapy just after their surgery, and has found very significant changes to lead to what will be a change in practice around the world for women who have BRCA-related ovarian cancer. So these women took maintenance Olaparib after they had completed their ovarian cancer-related surgery and chemotherapy, with now around 40% of women not having relapsed since they've completed their Olaparib treatment. This is really different. If you can look at that green curve there that tracks down towards the bottom of the screen, these are the women on the study who were taking a dummy or a placebo drug. The line across the red represents those women who were given Olaparib. This was a blinded study, so women weren't, or their treating team were not sure who was taking what. But this trial will absolutely change the treatments for women here in Australia who are discovered to have a BRCA change associated with their ovarian cancer. Sorry, the other thing about this trial is that you can see on the right-hand side, there's one hand that holds a handful of capsules. In the other hand, there are 4 tablets. So this was a trial that looked at the use of Olaparib in tablet form rather than capsule form, and has proven benefit with the capsule form and also tolerability amongst patients. So there is a move afoot in Australia for us to be able to utilise the tablet forms of treatment. I couldn't possibly do a talk without including some of the genetic changes that have also been found in the last few years. So if you have a look at this pie graph, the blue represents the number of women with hereditary ovarian cancer who have a change in the BRCA1 gene. So the vast majority of women who have hereditary ovarian cancer have a change in this gene, the second most common being the BRCA2 gene. But if you have a look in the pale blue section, you can see that there are a large number of other genes that have now been found to be associated with an increased risk for hereditary ovarian cancer. These can be grouped into several groups. The first group, group 1, RAD50, RAD51C, BARD1, PALB2, CHEK2 and NBN, are all associated with a state called homologous recombination deficiency. BRCA1 and BRCA2 are also genes associated with this deficiency. And PARP inhibitors, the treatment that I talked about associated with the SOLO2 trial, is something that takes advantage of this homologous recombination deficient state. So there is quite a possibility and quite a lot of excitement around the fact that there will be additional groups of women who might also have an advantage of taking Olaparib in the maintenance setting after their first line or in the recurrent setting. The second group of women are those who have mismatch repair genetic mutations identified, and there is growing understanding that immune-based therapy can effectively treat cancers that are occurring in the setting of this what's called mismatch repair deficiency. So again, a more treatment-focused basis to the possibility of treatment for their ovarian cancer. Ovarian cancer improvements cannot be achieved without significant collaborations between hospitals, ovarian cancer research cooperatives, universities, ovarian cancer interest groups, and study groups. Research can be pharmaceutical-led, it can be led by investigators, it can also have consumer drivers, but it also absolutely requires willing and brave patients and their support from their families. So thank you for listening, and I'm happy to take some questions at this time.
Thank you. Thank you very much, Dr. Antill, for that valuable presentation. We do have one question for you. If someone's asked, if I've had testing for the BRCA gene and it's come back negative, should I be getting testing for the other newer known genes that you mentioned?
Well, that's a really interesting question, Vanessa. I think it depends when the person had their ovarian cancer genetic testing, and also if there is any other family history of breast or ovarian cancer in their family. If the answer to that is yes, and particularly if the type of breast cancer is triple negative breast cancer, then yes, I think there would be a recommendation to consider going back and having a look at some of those other genes that are on the newer panel. But if a woman was older at her diagnosis of ovarian cancer and there is no other history of ovarian or other types of cancers, in particular breast cancers or triple negative breast cancers, then perhaps I think the genetic testing has been done as completely as it possibly should be.
Great, thank you. And just one more question. Are there any new treatment options for P53 gene changes?
Yes, I can see that there are a couple of questions about P53. The world is waiting for a treatment-focused targeted therapy for P53 changes. P53 changes are extremely common across a number of cancer groups. including high-grade serous ovarian cancer. P53 gene changes are often associated with a much more aggressive form of cancer, and I am very happy to say that there are some very early clinical trials that are starting to look at a treatment that might target P53 mutations associated cancers. These won't be all P53 mutations, they are a select type, but it's a start.
Fantastic. Well, we'll be looking out for newer treatments in that area. We'll leave it there, just looking at time. Thank you very much, Dr. Antill, for presenting and for giving up your time of an evening. It's very much appreciated.
Thanks very much for having me.
Okay, so I'm now extremely very happy to introduce our second speaker, Dr. Tarek Menyawi.